Stanford, Harvard, Yale. You joined the group about 5 years ago.
Right.
I just want to see, what have you learned to this point? Where do you see the industry growing into? And basically your positioning here as an interventional radiologist and how it applies to vascular surgery.
I think venous disease is really the largest area of growth in terms of vascular disease. I think in the last 4 to 5 years, we've just seen the beginning of what is yet to come. And initially, there's been a lot of work with new technology, dealing with the greater saphenous vein, improvements in sclerotherapy, and a more accurate and efficient treatment of deep vein thrombosis, also of dealing with diseases of the large central veins. As an interventional radiologist, I think we're well positioned to treat the superficial veins, the greater saphenous veins, but we're even better positioned to treat the large veins in the iliac system. And these are processes that can occur in any age group. They can occur in young patients. We see them in athletic patients when we talk about upper extremity veins. The constellation of these great vein syndromes or diseases is really across the board in terms of who your patient population are. So I think the future is very bright in terms of what we have and the technology available to treat these patients.
Define interventional radiologist, and if I have venous insufficiencies, how does that apply to my needs?
When you look at an interventional radiology practice, you're looking at a set of physicians that have been trained not only as diagnostic radiologists, not only as someone who is able to interpret, whether it's the ultrasound, the venogram, CAT scan, but also have merged those technical skills to have and ensure better treatment. So it's a combination of therapeutic as well as diagnostic evaluation. And as someone, as an interventional radiologist who basically works in minimally invasive therapies all over the body, we're able to use these tools that we may use in other parts of the bodies to treat the deep vein system.
Now, as a group, what is your focus?
Our group is part of Miami Vascular Specialists, so we have a number of interventional radiologists as well as a number of vascular surgeons that work together. We offer a combined approach in dealing with each patient individually in order to establish what's the best treatment and who is best able to treat that patient with their skill set. I think all of us have different skill sets in terms of our radiologists, in terms of our vascular surgeons, but we're able to come together and determine the best treatment options for our patients.
You work with a really strong group, some of the top physicians in our country, and like I said, you've been here for 5 years just about. What in this 5-year journey have you learned from these individuals?
Having multiple people or working together in a group is always beneficial for the patient. It's also beneficial for the treating physician, but it's also beneficial for the patient because you're able to call on all these different skill sets to figure out what's the best treatment option. You're able to work together. A lot of times we collaborate together in our treatment plan. You may have 2 or 3 interventional radiologists or a vascular surgeon interventional working together to try to reach the goal, which is to help the patient.
Give me the brief on each of you guys.
At the Baptist Cardiac Vascular Institute, we have our founder, Barry T. Katzen, and is incredibly well known in terms of vascular as well as venous disease. James Benenati, which is also a pioneer and has been working as an interventional radiologist for over 20 years. And not only is he a skilled interventional radiologist, he's also very well known in terms of from professional societies. We also have Dr. Alex Powell, who's been here over 12 years. He works doing all types of interventional radiology. Dr. Sean Samuels, over here almost over 2 years. We also have our new associate, Dr. Ripal Gandhi, who comes to us from UCLA, also embarking and working with us in terms of treating patients.
We're sitting in the center of a discussion about reform and how things may or may not affect groups like Baptist Hospital. From your perspective, do you feel there's going to be any changes that are going to be significant in the growth of your industry?
I think it's difficult to say what effects healthcare reform will have on the industry, on patient care. I think it's too early to tell. I know that at the present time, technology and the advances done, particularly in venous disease, have been immense. What we hope is that the changes occur in a way that do not stifle innovation, that we continue to be innovative, that we continue to find new, efficient, and effective treatments for our patients.
Let's discuss some of the diseases that are involving the industry right now. How do you treat them? Where's technology at? And what's your take on it?
There are several entities when we deal with venous disease that extend from the scope of simply the lower extremity and the greater saphenous vein. We've had a significant amount of experience dealing with deep venous occlusions as well as almost congenital type of occlusions or near occlusions. When we talk, there's a syndrome called May-Thurner syndrome, and May-Thurner were two different surgeons that described a narrowing of a vein, usually affects the left leg, where anatomically that vein is compressed, and these patients may suffer chronically from swelling in the left leg, and definitely a discrepancy between one leg and another, and these patients may be more likely to have more type of deep vein thromboses and episodes of clots in those legs. We talk about the same type of compression type syndromes may occur in the upper extremity, especially in patients that have repetitive injury. We see them in swimmers, we can see them in young backpackers, we can see them in weightlifters, where you have a compression of the vein as it comes into thoracic inlet, and they may suffer from swelling of one of the arms. And this is something that we're able to treat. We use new technology, instilling medicines to help break up the acute clot and thrombus, and then we're from there able to send the patient to surgical procedure where they get the decompression of that vein in the upper extremity. Another very interesting venous type disorder is pelvic congestion syndrome. There's a large number of females that may suffer from chronic pelvic pain, and this is a very difficult diagnosis, but may be related to reflux and incompetence of the ovarian vein. These patients may suffer from dyspareunia and pelvic pain, and this is a type of disorder that we're able to diagnose and treat by treating that refluxing incompetent ovarian vein using a number of small coils, which are vascular devices that help plug the vessel, as well as a sclerosing agent to help sclerose these vessels.
Is this technology relatively new?
This technology is not new. I think these are technologies that are existent, but be able to apply them and be able to find these patients is new. Now that more and more people are understanding that venous diseases occur, people understand that there is a whole family of venous disorders.
You have a strong educational background, and you obviously work for one of the top centers. If you could give any advice to somebody, what would that advice be?
I think it's very important to differentiate the treatment of patients from the business of medicine. One of the most important things is to understand the patient always comes first, and being able to treat the patient in the best manner possible. When the business of medicine stems from that motto, you're always going to do the right thing. New technology allows us to do this less invasively, more efficiently, with better results.
It's amazing to see where we are as an industry today, 2009, and where we can be in just 5 years. Just looking historically where we've come in just 5 to 7 years.
That's a very important point, in that especially if changes may threaten that growth. What is the impetus for this technology to continue to grow? What's the impetus for us to become more efficient? What's the impetus for us to better treat patients? Obviously, technology has a cost, and someone's going to have to foot that cost. So we can figure out the balance and establish which of the technologies are worth that cost. Those are the technologies that are going to progress, and technologies that are going to be effective.
In closing, obviously I'm sitting here, we're discussing best practices and your background and how interventional radiology actually applies to vascular surgery. Coming from Best Vein Care, what do you think of this model?
I think the intent of having some manner that physician and physician groups are evaluated and in a way follow certain criteria, I think is important. In medicine, you need to have a certain level of trust and a certain level of integrity, in that patients, when they come to you, that's something that they hold very dear. And I think it's important to be able to have a manner that will hopefully help patients and other doctors evaluate that.
Dr. Pena, thank you so much.